Let's see. So, I just want to warn you up front. Today is probably going to be the most accounting-ish session we have. I try to keep these, at a high level, relevant to you, so you make decisions, and we can talk about anything like that. But today is really about learning how to read financial statements and why that's important. Okay. So we've got, a PowerPoint, which I've done up. It's got about 20 slides in it. But a lot of it is taken from this document, which is the monthly write-up that I give to the Finance Committee, which actually met this week, Wednesday. So this is very current information. And so we'll kind of be going back and forth. And my real objective is that you could read this, you could understand it, and in particular, as you go back to the last few pages, which are the financial statements, you can look at that without your eyes glossing over, and know how to dissect it and understand. So, and basically, anytime any business you went into, you'd be able to say, "Let me see your income statement." Do you know what you're looking at? Things like that. Okay. All right. So. First part is detailed income statement, balance sheet, cash flow. Second part is, ratios, why they're important, how you use them. And then the third part is kind of coming back to this and stepping through it and asking questions. As usual, just jump in anytime. Talk about anything you want, go a different direction, whatever. It's really, to meet your needs. So, okay. All right. Now, this is a slide from last week. Okay, I've made a few little edits on there just as a reminder, but let's start. So, what are the three financial statements?
Income statement, balance
sheet, and cash flow. Right. What do you use an income statement for?
operating performance,
Perfect. And how about a balance sheet?
financial health,
Okay, and cash flow.
explaining why cash changes.
Perfect. Okay. All right. And I put the formulas up there. We'll be going through this again. So income statement is revenues minus expenses equals cash flow. I keep repeating that because it's the key to understanding the income statement. It's the key to dissecting that document and making it understandable. The balance sheet is assets equal liabilities plus equity. And are you asking a question or just stretching your thumb? Okay. And then statement of cash flow. Okay. All right. Now, so a few notes about financial statements. The whole reason we do this, we go through this exercise, is we're trying to provide information that decision makers can use to run an organization. So in this case, the decision makers are the management team, including all of you, and the board of directors, and in our case, sometimes the county. Okay? So, answer basic questions like, well, what's going on with the company? Are we close to budget? If not, why? What's working, what's not? Where do we need to focus our attention? Do we need to do something different? Is our plan good? Do we need to change the plan? Things like that. So in doing that, one of the things we do is we provide comparative information. When I give an income statement, I don't just give a statement that says, well, here's how we did for the month. I said, well, here's how we did in relation to the budget and in relation to the prior year. So you can kind of compare information. The balance sheet has comparative information. It shows how the balance sheet changes over periods of time. And what we do is we try to highlight things that are of importance. Okay. Now the reason we do these things is because of this. So when I started out in accounting, took my first accounting class in college back in Los Angeles in 1973. Okay, that's how old I am. Freshman. They said, okay, well, there's a foundation for the science of accounting. Okay, and the foundation are these principles, and it all has to do with providing information to decision makers. So what are the principles? Well, there's actually four, and they've never changed. So one thing is timeliness. If you're providing information, it's got to be provided within the time horizon of somebody who's going to use it to make a decision. It's not going to do any good to produce financial statements 3, 4, 5, 6 months after the fact, because then, it's way behind you. It needs to be current. So like when I arrived here in July of 2014, they had not produced the statements for March yet and weren't intending to, and in fact didn't for a couple of months. So they were like 5 months behind. So the statements weren't timely. Okay, well that's a problem because you can't make decisions. You got bad information. The statements have to be reliable. Okay, what does that mean? Well, in accounting, there are a lot of estimates. Okay, when we actually produce these financial statements, things like how much are your receivables worth? Okay, so we have this huge amount of receivables, but we have to value them because we're not sure how much we can actually collect. So we have to have methodologies to do that. So there's a lot of estimates. If we have, for example, potential malpractice events, they may be just notified, they may be in litigation, but we have to estimate what the potential cost of that is going to be. So we make estimates. So the concept of reliability has to do with, well, how good are those estimates? Are they within a reasonable range? So one of the things about accounting, when you produce financial statements, and there's an audit opinion, so you have an auditor and he expresses an opinion. The auditor never says every number in this set of financial statements is exactly correct. What he says is they're reasonable, you can rely on them, meaning that they're probably pretty close. Now an interesting thing happened last month actually. If you pull this report out and if you look at that first line and the third word, it says the reporting reliability issue that was discussed last month has been addressed. Okay? Well, what does that mean? Well, it means that last month when we did this, we came in and we said, we're going to give you these financial statements, but you really can't rely on them because we're not sure they're right. And the reason is we have a systems issue having to do with receivables where, there's this umbrella system called the general ledger, which is where you keep all the financial information. And it is used to produce these reports, but then it ties to what are called subsidiary ledgers. And there's a ledger for receivables, okay, amount of money people, well, it got out of balance, it didn't tie. Usually this is supposed to tie, didn't tie. Somebody got in and they were trying to fix another problem, and another issue here is that we haven't had really a real test environment for the computer system, so somebody went in and changed it in live and it blew up and it didn't tie. It was off by $23 million. So we said, we really can't tell you that these are reliable financial statements. I think they're approximately right, but I don't know. So this month we're saying we've at least got to the point where we can do a manual reconciliation to a sufficient degree to say that these are reliable statements. There's still systems issues because the thing still doesn't tie to each other, but we're trying to fix that. Okay. Next thing is materiality, and this has to do with all those estimates. Because what we want to say is, well, what is a reasonable range of error? And for our organization, plus or minus, $2 million is probably the range of reasonableness, Okay. So earlier in my career, I was in the Air Force, and one of the last things I did was develop the cost estimate for the B-1 bomber program, big construction program, 100 bombers. And I said, well, how accurate? I said, just round off to the nearest $100 million. Close enough for government work. Yeah, $17.9 billion. So close enough. But here it's about 1 or 2 million is probably reasonable. Now we try to be obviously more accurate than that, but it just depends. And then finally, it's got to be meaningful. So the information we provide has to mean something. It can't just be a bunch of gobbledygook. It's got to tight operations. And yes.
I'm sorry, is your mic on? I can't hear you, but it's kind of a struggle.
Okay.
Gotcha.
Oh yeah, so it's not broadcasting, but I will try to.
There's a fan competing with you that's coming.
Oh, okay. Why don't you just bring your chair up and put it right here? Okay, I'll try. Okay, so here is a income statement. And what I've done is I've tried to break it down. And I know this, so you're going to look at this and say, well, this is just a bunch of numbers, right? Okay, so really what I want to do is talk structurally about how this report is put together. And so you can pull this up and you can either turn to the second page, which has something very similar, or you can turn all the way to the back and look at the full income statement. So what I've done here is I've just taken out pieces of the income statement and separated it, and I do it that way because just like you know, the board sees this and their eyes gloss over and you know, you can't read anything, okay? So what I'm trying to show you here is the structure. So first of all, this is just the revenue section. So remember, income statement, revenues minus expenses equal income. This is the R, revenue. So all this information from 1 to 40, from actually 1 to right in here, 19, and then I just put some supplemental information down here, is revenue, okay? And so the first clue is there's a lot of lines on here, like 19, 20 lines. But if you go back to that formula, revenue, okay, R, revenue. So that is on this line, line 19, revenue. So if my first question was, well, how much revenue did we have, and this is April, for the month of April, what is the answer to that question? 74 million. And you can round. You don't have to go 74.088 because we said, you know, within $1 million is reasonable. So you can we tend to round. You know, we drop the zeros off the end. Okay. And how about for the year? How many? For the 10 months ended in April, that's this number right here, 749. Yes, almost $750 million, right? Okay. So the left side is really talking about where that revenue comes from. And then across the top, what we do is we've broken it into sections. There's really 3 sections. There's the month to date, which is the current month. There's the year to date, which is however many months that is, which is 10 in this case. And then there's last year, year to date. Okay? Now, why do we do it that way? Well, because, you know, you might care about how you're doing in the current month compared to the year to date, all right? So in this case, 74 million for the month, 749, 750 for 10 months. So that's pretty close. 74 times 10 is 740, that's 750, it's pretty close, okay? And there's fewer days in April than some of the other months. The other thing we do is we can then compare the actual, if you look across the top, it goes actual, budget, variance, that's a dollar variance, and then the percent variance, right? So actual, the year-to-date, actual, budget, variance, percent variance, okay? And then we have year-to-date. Okay, so what that allows us to do is rapidly dissect this thing and break it into pieces so we don't have to look at all the numbers, we just have to look at a few of the numbers to figure out what's going on. And then if you are interested, you can get into more detail. Okay, so what I would do is I look at this as a CFO, I said, okay, revenues for the month are above budget by 1.8 million. Pretty good, happy with that. Year to date, above budget by 20 million. Pretty good. I can know the variance, 2.5% there, 2.8% there. Pretty good, happy. How are we doing year over year? Well, last year we had 684. This year it's 750. So that's $66 million more. 66 as a percent of 684 is almost 10%. So our revenues are up 10%. Cool, really good. That's very unusual in healthcare. Usually you're going to see like 3, 4, 5%. I think our budget next year is like 6. Okay, so not as good, but we've been improving. One of the meaningful, useful messages I've been providing to the board since I got here was we have a big opportunity on revenue. We need to invest in improving our revenue cycle. We can get more revenue. So now I can come in and say, hey, guess what? We're getting more revenue, okay? Now, then the question is, well, where is that coming from? Okay, so we have 2 kinds of revenue. We have revenue, what we call patient revenue, which is where we send a bill out and get paid by somebody. And then we have supplemental revenue because we are a designated public hospital. We have a series of government, county sponsored programs that give us money, okay? So the way we've broken this out, and this is down the side, this is where the revenue came from. We have patient revenue here, and we have supplemental revenue there, and we add them together, okay? So 43,580 plus 30 million equals 74. So of our 74 million, 30, so 3/7 comes from these supplemental programs. That's a lot. In the year to date, 262 million out of 750. So really about a third. Okay, about a third of our revenue comes from these supplemental programs. Okay. All right, well, let's look at patient revenue first. So the way patient revenue works, there's something called gross charges, which is each of you has a charge master for your department, and when you provide a service, it takes the units that are provided, whatever they are, respiratory therapy, test, whatever, times the relevant code, multiplies it out, and that is the charge, okay? Now, we don't get paid anywhere near what the charges are, okay? In fact, we get paid about 20%.
We used to.
Used to, yeah, a long time ago. But one measure of efficiency is how much of those charges do we collect, all right? So we track that ratio on here, and it's further down in the income statements, line 44 and 45. But this is the collection ratio on net patient service revenue. So for the month, it's 18. For the year, it's 20.2. And last year, it was 22.3. Does everybody see those numbers online? Yeah, okay. So we actually didn't do very well in the month of April, right? So something's going on there, so you might say, well, what is going on there? Well, one of the things that's going on there is that we're getting ready for the audit, so I'm looking at the reserves on receivables, because that's one of those big estimates. It's going to get audited, so there's going to be somebody who's going to look at our calculations and express an opinion, and I want to make sure that that's conservative, okay? Conservatism is also sort of another principle. So that kind of explains the 18, but on a year-to-date basis, we're actually below as well, okay? So that's not particularly good. On the other hand, we increased a lot from last year. So what that's saying is we had this budget assumption that we're going to have a huge improvement in collections, and we did pretty well, but not as much as budget. Okay, so it means there's more work to be done on the revenue cycle. We're not getting every dollar we can. Another thing to look at is this gross charges. So these are all these gross charges, and we actually are above budget on there. So on a gross basis, we're above budget, meaning that the volume is probably better than budget. Okay, so patient activity, and we have I think on the next slide, a series of volume indicators. Oh, we have some here. So here's acute discharges and acute patient days. So you can see discharges were down, but days were up by 1.6. Year to date, the patient days are over budget by 5.8. So we've grown. We're seeing more patients than we used to. And that correlates to gross charges. Obviously, there's a lot of other things than a patient day, all kinds of tests, but it's kind of a proxy. So just looking at revenue, okay, you can say, gee, you know, we're doing pretty well on the gross, but we have a collection problem. We've improved, but we're really making it up on supplemental revenues. So we have a 31 million positive variance on supplemental revenues, which is good. Okay, and we have 262 million so far, and last year we had 248, so that's increased as well. Okay, which is good. And then you can see where. Here are all the areas: Medi-Cal waiver, Measure A, which is sales tax, various programs, DSRIP, supplementals, blah blah, all the way down. And if the board wanted more information, we could dig into those. Okay, yeah.
So how does the percentage of collection compare to similar organizations in our community?
It really varies by everybody's pricing strategy on their charge master, and it varies quite a bit. Although one of the things we found looking at this is Alameda hadn't changed its prices in like a decade. Okay, yeah. So we went in last year and we increased our pricing by 20 to 30%, huge. So one of the reasons you're seeing this collection ratio drop from 22 to 20.2 is we increased the denominator in the equation, which is our charges. Okay, and you can see that because the gross charges went from 1.9 million to 2.4. Large part of that is just pricing increase. Some of it's volume, but a lot of it's pricing. Okay. Then the other thing is the contract rates. So we have an issue with contracts because many of our contracts hadn't been done for years. We have an issue at Alameda Hospital where really the hospital failed largely because they did not address contracts. They said we have to have contracts, and they got contracts and they were terrible. They lost money on every patient they saw. So we're taking a different approach and we're trying to get the contract rates up so that they can be profitable. So the ratio here, the collection ratio is a function of what you collect divided by what you charge. And 20.2, that's really not that far out of line with others. The advantage we have is we have, in addition to that, we have these supplementals. And so we also do a calculation here on line 45 for total collections, which is this number, 74, divided by that number. Okay, the other one is this number divided by that number. And there, we're at 30%, 31% actually above budget. So we're actually doing better than we expected on our total collections. 31, and 31 is actually very good.
Not any
So
supplemental.
it's actually very good.
If there was
That would be a big problem because we would have to make it up somehow. We'd have to make it up. We would either have to find another source of revenue or we would have to reduce expenses to cover it because revenues minus expenses equal income. If revenues go down, income will go down unless you do something different. Okay, and that's actually a problem we're trying to solve right now.
How frequently do the supplementals swing or change?
All the time, all the time.
Significantly?
Yes,
That's,
yes, and there's some big changes coming.
Yeah.
So yeah, okay. You'll get that at a future lesson when I talk. Okay. So revenues. Anybody? How's everybody doing on revenues so far? Okay. I'm sorry to drag you through this. I know it might be a little boring, but this is the nuts and bolts. Okay. Okay. So we talked about revenue, and I had provided some description of it. Now we're going to go to operating expenses, which is also on here. Okay. So similarly, now you got this big bunch of numbers. But go back to the formula. Revenue minus expenses equal, so E is expenses. So E on here is on line 35. Okay, so first thing, so you're looking and says, okay, I know what the revenue is. I kind of understand where it's coming from. Now let's look at expenses. Okay, well our expenses are what in April? 71.6. Pretty good. Is that above budget or below budget? Above budget. Okay, so we're over budget by how much percent? Okay, and how about on a year to date? 3.1. And how about compared to prior year? 703 to 729, we're up about 3%. Okay, so we had budgeted actually to be pretty flat, which if you remember from last week's conversation, I had that one graph where I said 10% a year, 10% a year, 10% a year. And so we said, no, that we've got to do a turnaround. So we're going to keep it flat. That was the plan. We're up 3%, but it's offset by revenue. Okay. Now we also put income on here, so the I is right here. And how are we doing on income, say for year to date? What have we done on income? Yeah, year to date is about 20. And that's just below budget. So we're about 1.4 million below budget. Okay, so revenues has been good, but we're over budget on expenses. Okay, so why? Now let's get into the details. So why are we over budget on expenses? Now expenses, you can kind of break down between labor cost, non-salary costs, which are things like purchase services, supplies, pharmaceuticals, and then like capital costs like depreciation. Okay.
Wouldn't those offset each other? Because if you have more patients, which are gonna bring in more revenue, then you're gonna have
You
expenses
could,
gonna have to
yes.
go up for your salaries and your
Yes.
supplies.
Yes, you would. You would think so.
Yeah.
And there's a couple of ratios that we use to track that very point. Okay, so those are at the bottom. So let's look at labor first of all. So let's look at paid FTEs. That's line 63. And this includes registries. So we put them in there because frequently what happens is we budget for a full-time position, we don't fill it, and then we have to hire registries. So we put all those together, okay? So how are we doing on paid FTEs? Pretty good. So we're at 3914 for the month, and we're at 3959 year to date, which is interesting. So we actually have fewer FTEs now than we did earlier in the year, even though the volume is going up. Ooh, that's a good trend. That gets me
See his
excited.
face?
That gets the CFO excited. Okay. So the ratio, there's a couple key ratios. One is paid FTEs per adjusted occupied bed. And here we're at 4.84. Budget's 4.97. Year to date, we're also below. Last year, we're at 5.21. Now we're at, year to date, 4.74. So wow, that's a big improvement. That's like 20%, almost, it's a big improvement, okay? The other is this called the compensation ratio. Compensation ratio is salaries and benefits and registry costs, which are right up here, those three lines added together, divided by revenues from the other page. Okay, so it's saying, well, of our revenues, how much are we spending on compensation? Okay, and last year that was 69%. The industry average is 55 to 60, so we're like way over last year. Okay, so we said we got to do something about that. And we're going to do that through a combination of increasing the revenue, but also containing salary growth. Okay. Yes.
Is there any adjustment made for where you are in the cost of living and
Yes.
what the market's bearing?
This is just real numbers. It's just whatever happens, happens, and if we give a raise, a COLA, then that's factored in. So year to date, though, this is down to 65.5, and for the month, 62.6, both below budget. That's pretty good. So we'd say, in terms of our expense problem, it really doesn't seem to be labor. Okay? And let's go see if we can figure that out. So here's the line for labor. Salaries are under budget. Benefits are under budget. Registries are over budget by almost $11 million. But in total, that's over budget by about $4 million, which is maybe 1% or less, which is probably explained by volume. Okay, so labor is not really the problem. So one way to figure out where the problem is to go down this variance column and look for anything in brackets. Because we have this convention we try to follow in accounting where if the number is like a negative variance, we try to put brackets around it. This minus that. Okay. So in our case, where are the key variances? Purchase services, yeah. So what?
Building equipment leases and rentals.
Yes.
What's the outside medical service?
So one of our types of revenue is called capitation, right here on back. That's our capitation, which is Health Pack. So we have a contract with Health Pack. It's a $35 million contract, and it says we are responsible to provide acute care services for these patients wherever they go. Okay, so if we come here, it's fine, we take. But if we have to send them to UC or to Summit, we wind up writing a check. Now, it's really important to have a good care coordination program to keep these patients in the system if we can, because we don't like to write checks to other people. We like to keep the money here. Okay? That's what that is. Okay, purchase services are up. So these are things like consulting, or contracted employees, things like that. So we're continuing to do a lot of redesign. I'm personally spending a lot of money on redesign, the revenue cycle. I probably spent $4 to $5 million this year. A lot of it was budgeted, but some of it has gone on longer than expected because we're not done yet. So IT spends a lot. There's a lot of other areas that we spend on consulting. So one of our strategies is fix our problems, get rid of the consultants. Okay? They're working on that. But right now it's a variance. Pharmaceuticals are over. Well, what's going on in pharmaceuticals? Well, we started a specialty drug program this year that wasn't budgeted, so that's we're now dispensing a lot. Now we're getting revenue in to cover it, but that's an expense variance. And there was just an audit of our 340B drug program saying a few years ago the paperwork wasn't filled out correctly. We have to write a check for $5 million back to somebody. So that's unfortunate. So I'm having to record that as an expense. Not happy about that. Okay, so this is the expense side. Some other, now we go to ratios. So there's an EBITDA margin. We talked about EBITDA margin, so we report on that. So we're at 5 there. Year to date 4.1. Last year 1.1. So remember we said the EBITDA margin is a measure of the efficiency of converting revenue to income. So we've gone from a minus 1.1 to a positive 4. That's 5.2%. That's big improvement. Big improvement. Okay. The other class said, "Well, how did you do that?" I said, "We'll talk about that in a future lesson." It was okay. Then we have a bunch of statistics: days, discharges, length of stay. Just useful because you can correlate it to revenue and expenses. Okay. So. Let's see. Do you think you could read an income statement? Okay. The secret is breaking it into pieces. Remember the formula: revenues, expenses, income, and then across the top, month, year to date, prior year. Boom. Then just correlate it. Pick the number you're interested in. Say, is revenues up or down? Why? Is it volume related? Is it collection related? Is it something else? How about expenses? Does it correlate to revenue? Where are the big variances? That's pretty much it. The rest is just, you can drill down and ask more questions, but that's essentially it. Okay? We don't actually spend as much time on the balance sheet here as some other places. And part of that is the ratios are in general pretty bad, but it's really because we have this contractual relationship with the county. Okay, so the formula for the balance sheet is assets equal. That's assets are right here. I'm sorry. This is just the asset side. Assets equal liabilities plus equity. So in terms of our assets, how many total assets do we have? 448. 448 right there. And now we can do the same thing. So this is the kinds of assets we have, and these are the comparative periods. Now this looks a lot different than the income statement because we don't have a budget, we don't have a variance, we don't have a percent variance, have none of that. Okay, what we do have is the current month, the prior month, and the prior year end. That's standard. Everybody does it that way. And the reason is to talk about the health of the organization, which is the balance sheet, you want to look at certain points in time. And you want to say, well, how are we doing compared to the prior year? So, for example, one thing is, how much cash do we have? Okay. So the answer to that currently is 5.6 million, which is not a lot. Okay, so one measure of health is your ability to pay current bills. So let's just ask a question. How much do you think we spend every day to run this place? Let's come back to here. Here's our expenses for 30 days, $71 million. So about 2.4 million a day. Okay? Every day, 2.4 million. Okay, now come back here, and so how much cash do we have? How many days, if we had no receipts coming in, We have about 2 days. About 2 days. We stay in business for 2 days.
Isn't that that's the health organization, you're supposed to have so many days of cash on hand.
Yeah, and we're going to talk about that, what most organizations have. We don't have that. Okay, and the reason is that we have this line of credit with the county. We owe them today about $130 million. And part of the arrangement is, the way I explain this is, the last class is, there's a golden rule in finance. And the golden rule is, the person that has the gold gets to make the rules. Okay? And in this case, that's the county. So their rules are, we will lend you money, but every nickel you collect goes straight to them. And then if we want some of it, we have to ask for it. Okay, so we really have no cash appreciably at any one point in time. So we have 2 days cash. What we do have is the ability to, send a memo to Steve Manning and say, Steve, can we have money to make payroll? Okay. Now that's important because when things are going well, we're healthy, he will say, yeah, no problem, here's the money. When things are not going well, he could say no. He could say no. And he's never said no to payroll, but he has said no to vendor payments because we send them in separately. We say, can we have money for payroll? And then can we have money for vendors? And if he thinks he's going to be close on payroll, he will say no to the vendors because he doesn't want to say no to payroll because what would happen? People would be really unhappy. Okay, and there'd be people, they'd call not only him, they'd call the people that he works for. Okay, so we have very low cash. What about receivables though? So what are receivables? That's money that we should collect. Remember I talked about valuing? This is the estimate of what we think we should collect, okay, over the next 60 to 90 days. $113 million. Okay, that's a lot of money. So if we could get that down, that would turn into cash, which would be a good thing, okay? And you can see it's actually down, just a little bit from prior year. This is June 30th of 2015, okay? But as I'm going to show you in a minute here, on a proportionate basis, that's actually a big improvement because our revenues have gone way up while receivables have stayed the same, so that's actually an improvement. So these are all assets. Then you have things like inventory, prepaid, other receivables. This money, $23.5 million, is ours, but it's held by the county. It's like it's one of those other rules that they put in place. It said, just on the off chance that we need to cover, a shortfall, put this money over there, which they can take if, we get in trouble. Then we have things like construction in progress, which is actually equipment, land and buildings and equipment, software, and then accumulated depreciation. And so we own about $80 million worth of stuff, which is pretty low. Okay, what do we not own? Well, we don't own this building, and we don't own those buildings. We don't own any of the buildings. Those are all owned by the county. Okay, and we're allowed to use them. I think we pay them $1 for using them. Okay, how much do you think the new hospital cost? $2, yeah. Any guesses? It's a.
657 million.
Yeah, there you go. Yeah, yeah, there you go.
That's cheap, next time.
Okay. Okay. So we have relatively low assets. So here's the other side. So assets equal liabilities, which is right here. Oh, actually, we don't put I need to fix this. We have current liabilities and long-term, but we don't add them together, so I need to do that. But that's about $724 million, which is more than our assets. So we have negative equity right here, $293 million, which is actually improved, but it's still negative. Okay? All right, so why is that important? Oh, first of all, here's some key ratios. So days in cash, we have about 2.4 days in cash. We know that. And then in net days in AR, we're down to 69. Now, a healthy organization should be like 55 to 60, but we're coming down from 90. So we have really, really improved. So we brought AR down proportionately, which means we have more cash. which means the amount that we owe the county has come way down. Okay. All right. And then finally, the statement of cash flow. We're almost through the really hard part, so thank you for struggling through this with me. So on the statement of cash flow, we're looking at cash from operations, cash we use for investing, and cash we use from financing. Okay, and there's are three things here, so you can break this down. And here we just do the current month and year to date. We don't do prior year, we don't do budget, we don't do variance. We just do current month and year to date. Okay, so you can see, for example, the cash we have at the end, 5556, is the same at the end of this month and the same at the end of the year to date because it's the same date. Okay, and the 5596 also ties to that number right there, 5596. Okay, all right. So what this does is it takes the income statement, 19,872,000. So if we go back to the income statement, that's 878. There's actually a few more things here but it ties out, believe me. That's where that number comes from. And then we essentially take here changes from the balance sheet, like that thing I talked about, receivables coming down. When receivables go down, that is a source of cash. Okay, that generates cash that doesn't show up on the income statement. If accounts payable, let's talk about accounts payable. So that's right here, accounts payable, line 28. So from the prior month to this month, the payables went up. Okay, so we owe more money. So what effect would that have on cash? We would have more cash because we didn't pay somebody. Yeah, we delayed payment, so we have more cash. So, like when we were having these financial difficulties, and Steve Manning was saying, I'm not going to give you money to pay your vendors, this number skyrocketed. This was up to like $60 million, okay, which helped our cash situation, but we had some really unhappy vendors. Okay, okay, so we've now got that fixed. Whoops. But anyway, so what we do is we look for items like that, the change in payables, receivables, prepaids, deposits, anything like that. And we take all those adjustments, say, well, okay, well, here's what we actually have generated from operations. So year to date, 2.6 million. And then down here we say, well, what have we spent money on? Okay. So for example, here, net purchases of property, plant, and equipment, 13.4 million. Investment in Alameda Health Partners, 2 million. Okay? So we can see where we spent money. And then down here we have financing activities, which in our case is borrowing from the county. Either borrowing or it could be negative if we're paying it down, which it will be by the end of the year. Okay? Okay. Whew. How was that? Any questions so far? All right. Now let's talk about why this is important. So, so healthcare is a capital-intensive industry. What does that mean? Capital-intensive means it takes a lot of expensive buildings and equipment to operate. Okay, it's not like, for example, say you start a business to write apps for the iPhone, okay? How much capital is involved in that? Not a lot. You need a computer, you need somebody who's trained to do this, and a good idea, right? Can be done fairly inexpensive. So that's low capital. But healthcare is high capital. Really expensive buildings, lots of equipment, expensive equipment, wears out, needs to be replaced, new technology, okay? So most organizations, if you go back to the balance sheet, so if you think of the formula for the balance sheet, assets is essentially capital. It's all the things you need. You need cash, you need receivables, you need equipment, buildings, boom, boom, boom. In our case, $400 million. If we counted the money the county's put in there, it's really $1 billion, okay? then the question is, well, where do you get that? And there's two places, generally two places. There's others, but the two classic places you can get capital are: you can borrow it from somebody, you could earn it through income, properly, or somebody could give it to you. It could be philanthropy. Somebody could be. It could be an investment if we're a for-profit company. As a not-for-profit, there's no stock here, so nobody can buy stock and give us cash that we can use to buy assets. So we either usually have to borrow it, or we have to have it contributed to us. Okay, but for most organizations, they have to borrow it, and so there's a market for that, and it's called the bond market. Okay, and what they do in the bond market is they measure the likelihood that the borrower can repay the money. Okay, and that's called a credit rating. Okay, and the credit ratings range from what's called AAA, which is the best you can be, which is the United States government, to down through AA, single A, goes triple B, double B, single B, C, and it even goes down to D. Okay. And what happens is the interest rate varies based on the credit worthiness. So the better your credit rating, the lower your interest cost. And if we had to borrow $1 billion, 1% on $1 billion is a lot of money a year. Okay, so obviously you want to be more credit worthy than not. The other problem is that most of the people who buy these bonds are pension funds. And pension funds have a fiduciary duty to protect their investments. So they're looking for a good return, but they're also looking to avoid what's called a default, when somebody says, well, I can't pay you. So what they do is they draw a line, and they say above that line is what's called investment grade, meaning it's within our policy that we can buy these bonds. And below that line is called below investment grade, or junk. Okay, typically called junk bonds. Okay, and that line's right here. Okay. So Baa3, which is like a triple B minus, is the lowest you can be, and have somebody buy your bonds. You can still go out there. There are people who would buy below that, but the interest rates get really, really expensive. Okay, because they're risky.
So the kind of people that break your legs if you don't pay them.
Yeah, pretty much, yeah. So I just put up here some of the local organizations. So you can see Sutter, which I used to run, and I took them from about here to there, and then they've since gone further. Stanford, El Camino, John Muir, Dignity, Fremont, Rideout. We're over here, but guess what? We don't have a credit rating, because to have a credit rating, you have to issue bonds, and we don't do that. Okay. Now the county has a credit rating because they had to issue bonds. Why? Because they had to build that building, so they issued bonds, and the county is, I think, right about here. I think they're a AA right in the middle, so they have a really good credit rating. Okay. So we kind of get the advantage of that, okay, because we're closely aligned, okay? But, when I first came here, I looked at the strategic plan, and one of the strategic objectives was to obtain investment grade credit rating for Alameda Health System. I'm like, well, we're not going to issue bonds. So it just doesn't compute. So I think we've now educated everybody to realize that no, it's actually, the relationship with the county is what we really care about. The idea was, we're going to have an investment credit rating. We're going to get rid of the county, have it operate independently. And we said, no, that's not what you want to do at all. You want to have a very close relationship with the county. So, okay. Zap. Hang on. Okay, are there any questions about credit ratings?
So David, based on the strategy that you said was incorrect prior
Yeah.
to getting here,
Yeah.
why did the board not recognize that and correct the strategy, or recommend correcting the strategy?
I think they just didn't understand it, I think one of the questions for the other group was, well, how did you how'd you orchestrate this turnaround? And the first thing is just getting everybody on the same page with real information and what's practical and reasonable, and so yeah, so I think that we've come a long way, so that particular part of the strategy is out because it's just not realistic.
Is there someone on the board now who would recognize that had you not been here?
I probably not right now, but I think everybody understands it now, because once you explain it, it's like everybody goes, oh, well, of course not. You're not going to have a credit rating because we're not going to issue bonds. I mean, unless we have, $100 million project that we need to finance and we don't have the cash for, or can't get the county to do, then why would you? Why would you go through the effort? Because, it's expensive. We want to be credit worthy, but we're not going to have a rating, because there's a process you go through. There are several companies, Moody's, Standard & Poor's, Fitch, who provide ratings, but to do it, you have to, put on a big presentation about your history, your plans, the management team. Oh, and they have, when you actually get a rating, and it's kind of fun because you get to go to New York and go to plays and stuff. But these are the kind of things. They look at your financial trends, market position, governance and management actually plays a big role here. Who's running the place? Do they understand what they're doing? Their strategic plan, financial plan, trends, payer mixes, physicians, all kinds of different things that play into it. So, okay. All right, let's move on. Oh, yes.
So you're saying this was in our actual strategic plan
Yeah.
for our facilities, yet who wrote that strategic plan and why wasn't there follow-up to go with that? Because I thought most strategic plans would end up encompassing goals,
Yeah.
action plans.
Yeah.
And to see who was assigned that task, then they should have known not to.
Yeah.
That wasn't a feasible
Yeah. Yeah.
for us to even go down that route.
Yeah, so the plan was, the formal plan was written by a company called KSA, which is a consulting firm out of Sacramento that I've worked with in the past. And the financial plan was done by these guys, Kaufman Hall. Not this document, but they did another one in the past. And they came into it with a lens that is very traditional, like, oh, you want to be independent of the county, so you want to be like a community hospital, like a Sutter. And in fact, the strategic plan actually said, oh, you're gonna solve this by competing against Sutter and Kaiser and taking away commercial business from them. Like, I read that, I go, it's ridiculous. It's just not going to happen. And nor should it, because the real strategic advantage we have, which nobody paid attention to, was we are a designated public hospital, which means remember all that supplemental revenue? Sutter and Kaiser don't get that. Okay, we probably get paid 5 times what Sutter or Kaiser does for a Medi-Cal patient or an uninsured patient than they do. We get paid cost, essentially. I mean, there's some calculations which we'll go through in a future meeting, but we get paid pretty close to cost. So, I mean, our real competitive advantage is we are a DPH.
With healthcare reform, that's not changing.
There are a lot of changes, but we still are benefiting. The biggest change is that this thing called the Medi-Cal waiver is going away, and we're looking at that. But there are other programs that potentially could offset that. AB 85 cost guarantee is a fundamental part of healthcare reform, and was not well understood. And earlier this year, we figured it out and got a check for $60 million on one day from Alameda Alliance, just like that.
Because I thought
Yeah.
there was, I guess it was 5 years ago, or 2000,
Yeah.
6 years ago, 2010, when the healthcare platform was changing, and then there was DISRIB.
Yes.
And getting that process, and initially, when we started doing it here, the message was, we've got 5 years
Yeah.
to basically to get off of,
Yes.
learn how to live without the supplemental.
Uh-huh.
That was the entire goal. And so now it sounds like it's evolved where that's not necessarily the case, and I understand there's DISRIP 2.0, I can't remember the name of it,
Prime.
Prime. So it's still
Um,
kind of marching out along those lines, and we still have the supplemental.
Yeah, now Prime is scheduled to, we're in the first year of it. Its current plan is it's going to decline in each year and then drop dead at the end of 5 years. Dead. So we need to plan to replace that. That's not in this meeting, but I'll include that in a future meeting about what, how we're approaching that plan. But that is the long-term, strategic financial issue we're dealing with right now. And we'd have a plan for it, but, okay.
I have one other question I was gonna ask right before you ask, but so understanding what our competitive edge is with being a public hospital.
Yeah.
And that kind of funding, would there ever be a benefit to us? And I'm thinking of it in terms of, is there ever a goal in mind to separate from the county and to not have that financial relationship with the county?
That actually was part of the plan when I got here, and I don't think there's a reason to do that. I mean, we are independent of the county, but the DPH status we have comes through the county.
Right, so that's the.
So you have to keep that. So, like, for example, I'm dealing with an issue right now, the new building, okay? So, as a DPH, actually for most organizations, we get something called capital cost reimbursement. So the cost of that facility, as measured by depreciation, which we talked about, or interest cost. Interest cost on $700 million is still, like $28 million a year or something, maybe more. That should count on our cost report that we submit and we get paid basically 43% of it. So this potentially could be, 15 to 20 million a year in additional reimbursement that we're not getting right now. Well, why aren't we getting that? He says, well, when we file our cost report, remember we said we don't own the building and we don't pay rent. So we don't have any cost for that on our income statement. So we can't, under that mechanism, claim it. Okay, well, the county does. They have depreciation interest. They don't run a hospital. They don't file a cost report. So they're not getting it. So, but there's a regulation that says if you are what's called if you're related parties, as evidenced either by ownership or control, then they will treat you as if you're married and you're one organization and allow us to claim those costs, okay? So in the past, there was a few years where we did get it, but then there was a dispute around 2008 or 9, I can't recall, but the county wanted Alameda County Medical Center to pay more rent, and the people who ran the board of directors here said, no, we don't want to pay more rent, and there was a big dispute, and they didn't pay it. So the auditor looked at that and said, well, we know the county doesn't own you guys because you've got this document that says you're separate. And your argument that they control you really fails because they just tried to get you to do something. You said no. And you prevailed. So that they must not, yeah, just like a marriage. I love that movie. If you don't stop disobeying me, I'm going to stop telling you what to do. It's Woody Allen. No, so we're trying to change that fact pattern because that's the current interpretation is they don't control you. So well, wait a minute. They appoint our board. We're required to have monthly administrative meetings. They have to approve our bylaws, and we're trying to change that, change the interpretation, so that we can take all the costs from this new building, put them on our cost report, and get paid. A lot of money at stake. So this would be like $20 million a year for the next 30 years. That's real money. It's worth going after.
You have to ask permission to get the money for payroll, so that sounds.
Right.
Yeah,
Yeah.
yeah.
I mean, all of our money that we collect goes,
Mm-hmm.
and then we have to ask them to have it back. That kind of sounds like
Yeah.
control to me.
Yeah, and I think we would have prevailed. This actually was a lawsuit that got settled by a judge, and he said, well, the deciding factor was this one event where the hospital board demonstrated that it was not controlled by the county. So we have these private meetings, and one thing I would say is, look, whatever happens behind closed doors when we're out front, we're like this. Okay, all right. So that's credit ratings. Now, in determining credit ratings, they go through what's called a ratio analysis. So back on this one up here, financial trends, positions, payer mix, all this, they look at financial ratios. So I'm just trying to make sure that in this part you understand where these ratios come from and how they might be used. So there's basically three types of ratios. The first type is called profitability, which is, how efficient is this organization at producing a bottom line, given what they have. The second is liquidity, which is, do they have the ability to meet their short-term obligations? Okay, payroll, AP, okay. Now, typically, do I have that coming up? Okay. Like, for example, on days in cash, which is a key ratio, how much is ours? 2.4? They'd like to see about 150. Okay? Which in our case would be $300 million. All right? So we fall short on that. Other areas like days in AR, we're getting that in place. AP, we're looking okay. But liquidity is basically, can you meet your short-term obligations? And then leverage is really, do you have the ability to issue additional debt? Okay? And these different ratios, leverage ratio, debt to equity, capitalization ratio. A simple way to think of it is you can generally borrow as much long-term debt as you have in equity, 1-to-1. So if we went back to the balance sheet, just here, so we have long-term debt of $600 million, and we have equity of minus $293 million. So what is our ability to issue long-term debt? 0. Less than 0, okay? Less than 0. Which is another reason why this whole credit rating thing was just, okay. All right. But those are the three ratios. And we don't need to really go through the details of that. There's more operating margin, excess margin. These are all just different ice cream flavors over the same themes. It's still an ice cream cone. Liquidity, capitalization, things like that. Okay, and here's some calculations if you are really interested. These won't be on the test, so they're obscure. And I think I put this in here just because this came from Kaufman Hall. It was an initial financial plan, and it showed how, for example, Moody's, which is a rating agency, for the bottom rung, Baa3, which is the lowest you can be and have a credit rating, would like to have 147 days cash on hand. Here we are, and they'd like the capitalization ratio to be at or below 40%, and we're way up here. So this is just to show, really, we're not going to play in this market, so that's fine. Why did I put this in here? Oh, I think, did we do this one last time? Did we talk about the boom and bust cycle that this organization's gone through? Okay, I'll do it real quick, but essentially here's the operating margin, which is performance. This is where we started. We created AHS. And you can see very quickly they got into trouble and started losing bunches of money. And the reason they did was expenses were going up, double digits here, okay? Expenses were growing faster than revenue. So remember that? Revenue minus expense equals income. If expenses increase faster than revenue, income's going to go down. And that's what happened. They got in trouble. So the next thing that happened is the county stepped in and said, okay, we can't let these people go under, so we're going to pass Measure A. Okay? Measure A resulted in a one-time huge increase in revenue, and so boom, 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 they got back to break even. Okay? And at the same time that happened, the hospital here started controlling its costs. Okay, it had 1 year where costs were flat. Okay, they kept it down. They got the revenue, expenses started growing again. boom, boom, boom. See that? Boom, boom, boom. Pretty soon they're up over 10% 1 year. That's single year growth rate in costs. That's huge. What do you think we're planning for next year? 2 to 3. Okay. Remember I said this year was 3. We kept it about 3. Okay. So they did that, and they started, making a little bit of money or breaking even. Okay. This is what they were reporting. They actually, if you look at the cash flow, they actually weren't doing that well at the time. They were getting into trouble. And then came DSRIP right here. DSRIP came, and at the time they were controlling costs. DSRIP came, and then what happened to costs? Boom, 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 boom. Wow, how about that? What happened to profitability? Boom, 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 right back down. So when we meet with the county, DeVecca, one of the things they says, look, guys, you're doing a great job, but you're new. We've been here a long time. We've seen this. This is what's going to happen, and we don't want you to let it happen. Okay, it's gonna, you make money for a year or two, and you guys start having a party, and expenses get out of control, and don't let it happen again. So we're paying a lot of attention to that. Okay. All right. I think I put this up here just to show you what the budget is for next year. This is preliminarily. So we're expecting patient revenue to continue to grow. Here's 2017. We're actually expecting supplementals to be flat or down a little bit. Okay. So now you're starting to see the supplementals flattening out. And then the expenses to grow by about 3%. But EBITDA, we keep talking about EBITDA to actually increase. Okay? We're not done with this yet. I've got another budget review next week. And I put this up here to show you, this is an analytical technique we use for the board to help explain at a glance what's going on in the entire system. And so the way this works is across the top we have our business units, so Highland, Fairmont, Behavioral Health, Ambulatory, San Leandro, Alameda, okay, Alameda Health Partners. And then down here we have key metrics. So these are volume indicators, revenue indicators, expense indicators, and income performance, okay? And then what these numbers are, these are variances to budget. So if we, for example, have a positive, if we have a higher EBITDA margin than budget, then this would be plus. If we have a negative variance to budget, it would be negative, even though the absolute number may be, higher than 0. And so then what we do is we color code it, and there's a neat function in Excel where you just kind of highlight everything and say, pluses are green and negatives are red. And so the intent is to allow the board at a glance to say, okay, what's working and what's not. It's okay. So, for example, how is behavioral health doing financially? Okay. Can we tell why? How do their volumes look? Yeah, which is another issue. Financially, terrific. Clinically, there's a real problem because we can't take care of all the patients. Revenue yields extremely good. Expenses are actually pretty good. Slightly over in total, but volume adjusted, they look terrific because there's so many patients. How's ambulatory doing? Not so much. Yeah, not so much. So anyway, this gives us, it allows the board to easily say, okay, what should we talk about? Remember that meaningfulness principle? It said, okay, well, where should we be spending our time right now? Well, that's helpful. Okay. This is presented just to kind of show you, this is actually an old slide, but where we stand compared to our competitors. And actually, we're going to be close to 5% this year. And that's better than a lot of the hospitals around. It's lower than some others, but this is where we were. We were dead last, and now we're mid-range. So we really come up. Be happy about that. Okay, let's see. So, actually, before we do the test, and this is where I kind of wanted to switch over to this document a little bit and walk you through it. Okay. I don't know if anybody's had a chance to read this. Okay. So let's see. Well, first of all, has anybody read this? Does anybody have any questions about it so far? Let's walk through it. Okay. So the first it's from me to the Finance Committee. Okay. And it's pretty current, May 24th. So I wrote this last week. And the first paragraph talked about this reliability issue, because reliability is sort of a threshold, and we needed to get that out of the way. And then what I'm trying to do is deal with the meaningfulness issue by giving them the highlights. So the first thing in the second paragraph is we were profitable, both for the month, year to date, and we're slightly below budget. But the margin is 4.1%, the budget's 4.6. We're pretty close, okay? Then we go down. Now these are the significant trends. Patient activity, okay? Why is that important? Okay, because volumes drive revenue, they also drive expenses. So if we want to understand what's going on in revenue and expenses, the first thing is we have to understand the volumes, okay? So patient activity has been strong. Gross charges are strong. But ambulatory visits are below budget. So that's the one area where we seem to be missing are the visits in our clinics. And the reason is it's hard to get a patient into the clinics. It's actually hard. We have physicians standing by empty rooms, patients waiting to get in, and we can't get them in because of the...
It's a problem with our patients not returning back because they just don't, or a problem with patients being able to call in and get appointments and be able to come in for their things.
It's sort of all of that. But at the board meeting last week, Dr. Barbaria gave a presentation, which was really good, about her clinic. It was dealing with various issues, but one of them was access, and they have really improved it. Okay, and how? Well, they assigned somebody to answer the phone. That is essentially what she did, because we don't answer phones. Okay?
It's true, just going to the new building the other day.
And I've experienced, I went to the same day clinic to do a little thing on my hand, and I walk up, there's nobody in the lobby. It's like 8:30. There's somebody at the desk. I go to the desk, says, "Can I get in?" And she goes, "No, you have to call this number. You have to make an appointment." I said, "Okay, I'll do that." Boom, boom, boom. Hour later, I get in, walk back. Beautiful clinic, fully staffed, nice providers, no patients. Now, it's one day, so they picked up, but no, but that I think. So we're going to look very carefully at the front end process on ambulatory, because it affects everything else we do. Everything, And these patients, if they can't get in there and they really need care, they may go to Summit, and then we've lost them. So, okay. So volumes are important. And then we talk about revenues. So you can see I'm kind of walking through the income statement in my head. Talk about revenue and talk about why. And let's see, FQC audit reconciliation. Oh yes, okay, all right. In this case, there's a particular issue dealing with our FQ8Cs that is affecting revenue. So there's an audit hit there. It's something else we have to fix. We talked about supplementals being favorable, and then total revenue. And then we go to the next page and we give them a little schedule. So you've already been through the schedule already, so you should be able to read that. Then we talk about expenses. Okay, so we talk about this pharmaceutical issue, which is that 340B audit. So I didn't put a dollar amount in there, but I told them verbally that for the month it's about $1.5 million, and year to date 3, and then by the time we get to the end of the year it'll be 5. Okay. Talked about specialty drugs, labor costs, blah, blah, blah. Give you the same information, same little schedule, and then talk about EBITDA. Okay. All right. Okay. Okay. All right. Okay. Well, and then what I do is I go through here, and then I try to provide more information on the business units. We show the heat map and all that stuff. So I've kind of finished. Why don't we just, we're got 15 more minutes if you want to keep going. I'm happy to answer questions about this or anything.
Is it possible we can get those slides emailed to us, PowerPoint emailed to us as well?
Sure, if you'd like to have that. Okay. What I've done is I've got actually everything in one PowerPoint. So I'll have to break it out, but that's fine because as you can see, I haven't written number 3 yet, so I've got a little bit of work to do on the weekend. But I'm happy to do that. Let's see. Do we have anything that we haven't talked about? Test. Okay, so we talked about capital structure. That's that whole, we're not going to issue bonds, How do you think we're doing about generating revenue?
Better than we were, but not as good as we should be.
Yeah, that's probably a good answer. Okay, yeah. And how do you feel about our operating efficiency?
Getting better.
Getting better, that's good, okay. And how do you think we're comparing to everybody else in the area? Much improved, yeah.
Yeah.
Yeah, respectable, really respectable, yeah. Which business units are doing better and which worse?
Ambulatory's doing bad.
Yeah. And what's our liquidity position? What does liquidity mean?
Not great.
What's it mean?
How much we can get a hold of in a very short period of time.
Right. So we don't have a lot of cash, but what we do have,
True. I was thinking more cash.
we have the ability to borrow from the county.
True.
Okay. Now, our current liquidity is about, we have to be at June 30th, we have to be at 145 million. And today we're either 130 or 140 depending on cash. So today we don't have a lot, but we're about to get a big check for the Medi-Cal waiver, $44 million. And once we do that, we'll be in great shape. So,
Is that all gonna go to the loan?
yeah, it all goes along. Everything goes right there. So we'll be good there. And then, how well are we positioned to get a credit rating? Not realistic. Yeah, not going to happen. Okay, yeah.
Well, thinking of the business units, and I don't remember if this is an actual long-term plan or a rumor I heard somewhere about the rehab moving to San Leandro.
Uh huh.
Because it looks like Fairmont's currently doing really well, San Leandro maybe not. And if they merge, what happens to that?
They're actually both doing pretty well. We really have to move rehab because the building they're in is not seismically compliant. So it makes sense. And San Leandro does have a vacant floor up on floor and a half on 3 and 4. So that does make sense. One question I've got to solve is whose license they're on, because right now they're licensed under Highland. And if we move them there, would they be licensed under San Leandro or would they remain licensed under Highland? And a lot of their reimbursement is driven by their license. So, although San Leandro is now a DPH as well, effective July 1st, but so I've got that's just a technical detail I got to work out. But yeah, we're gonna start that this year. Okay. Other questions?
That is possible, Bill, right? I think I've heard something like that in the past, where you could have an entity within another entity.
Yeah, you definitely can. Yeah, you definitely can. Yeah, no question. Yeah, okay. Okay, well, if there's no other questions, thank you very much.
Thank you.
Have a nice weekend.